Hello, you are welcome again to the second aspect of our ongoing series on the course primary health care, and we are looking at the training and support of the primary health care workers. We have looked at the first aspect, and today we are looking into the second aspect of this lecture video. We have looked at introduction to PHC workers. Now we want to discuss historical context and global frameworks. Historical context and global framework. Now, looking at the historical context and global framework, we'll be discussing the Alma-Ata Declaration, key global case studies. We'll look at that of Bangladesh, family welfare assistance, and that of the Ethiopia Health Extension Program. Now we're taking it to the global aspect and also taking time to look at how it all began. So let's go back to where it all began. The Alma-Ata Declaration of 1978. My name is Dr. Isaac Boyin Henry, and thank you for coming back to my handle, and I know that you will enjoy this second aspect of this video. I advise that you take notes. I also advise that you take time to listen. You can always rewind when you need to. So like I said, let's go back to where it all began. The Alma-Ata Declaration of 1978. This historic event held in Alma-Ata, now it is known as the Almaty, Kazakhstan. And it changed how the world throughout, how the world, henceforth looked at healthcare forever. In that meeting that took place, a lot historically was put in place, and till date, healthcare no longer looked at with the lens before that date. It's no longer the same. A lot have changed. In that Alma-Ata Declaration of 1978, there the world agreed that health is a basic human right, and that the best way to achieve it is through primary health care, which is known as a PHC. At that meeting, it introduced a big simple idea: health for all by the year 2000. Health for all by the year 2000. That was what was introduced. And as time went on, of course, we didn't achieve that exact deadline. But then we all agree that the vision was powerful. Health for all by the year 2000. It said health shouldn't depend on your income, gender, or where you live. Communities should be actively involved in their own health care. And most importantly, community health workers are the key players in making that happen. Now, this idea inspired many countries to start community-based health programs. And today, we will look at some powerful examples. Let's begin with that of Indian ASHA program. What does it mean? The ASHA means Accredited Social Health Activist, India. Now, the India ASHA program created one of the, India created one of the world's largest community health programs with over 900,000 women trained as ASHA's agents. Now, what was the focus of this ASHA program or the ASHA agents? Their focus or their area of focus was maternal and child health, family planning, and sanitation and immunization. Was there any impact? The ASHA program has been seen to become a game changer. At the time, it contributed to around a 30% reduction in neonatal deaths, and it helped increase institutional deliveries across the rural India as people began to visit health institutions rather than giving birth at home. In fact, ASHA workers became trusted guides. They were linking families to the formal health system and promoting healthier living. Another example is the Bangladesh Family Welfare Assistance, known as the FWAs. The Bangladesh followed a similar community health model just like India did. These family welfare assistants are trained community women who focus mainly on number one, family planning education, number two, immunization and material health wealth. And we must take note of these focuses. Like I told you, that of the ASHA focused on maternal and child health, family planning, sanitation and immunization. That of the Bangladesh Family Welfare System focused on family planning, education, immunization and maternal child health. You can see that they are very similar. There's almost the same goal. In fact, from the same root or from the same idea, pursuing almost the same goal. They helped cut down infant mortality rates significantly and increased family planning acceptance nationwide. This is a strong example of how consistent community contact and simple preventive care can transform national health outcomes. Another example is Ethiopia's Health Extension Program. Ethiopia Health Extensions Program. Ethiopia took community health even further by training thousands of women as health extension workers. Their training focused on hygiene, sanitation, disease prevention, and basic curative care. And what was the impact? It was observed that immunization coverage increased from 30% to over 70% within a few years. That's a wonderful impact. Number two, they noticed that rural communities gained access to services that were previously out of their reach. In fact, Ethiopia proved that empowering women at the grassroots can rapidly expand national health access. In summary, as we look at this aspect of the Alma Ata Declaration in 1978, we see that the Alma Ata Declaration laid the foundation. And these country programs, like the Indians ASHA, Bangladesh FWAs, and the Ethiopian HEP, followed how PHC and community participation can move the world closer to health for all. So as we round up this slide, I need you to understand that global evidence shows that when we train, when we support and trust community health workers, we don't just improve health, we are building stronger and more equitable societies. Let's look at slide 16. With this, we'll take a quick trip back in time because understanding where community health work began helps us appreciate how far we have come. Between 1950s and 1960s, China's barefoot doctors in rural China existed. There weren't enough doctors to serve the millions living in the villages. So the government came up with a brilliant idea: train local community members in basic healthcare skills. These people were called barefoot doctors. I'm sure you must have wondered, why the name barefoot doctors? Why such a name? This was because they were mostly farmers who walked barefoot in the fields. And after short medical training, they combined both the farming with basic healthcare services. They learned to treat common illnesses, number one. Number two, they learned to give vaccinations. Number three, they learned how to promote hygiene and sanitation. And finally, number four, they learned how to educate people on nutrition and disease prevention. This initiative became the foundation of modern community health workers programs around the world. And it proved that you don't need a hospital in every village. Sometimes training one trusted person can change the health of an entire community. The Alma-Ata Declaration, fast forward to 1978, where the world gathered in Alma-Ata, now Almaty, Kazakhstan, for a global health conference organized by the WHO. At that place, the world officially embraced primary health care approach, a powerful, people-centered way of delivering health. And the declaration boldly stated that health is a fundamental human right, and that community health workers are essential to achieving health for all. From that moment, countries around the world began developing their own community-based health programs, inspired by the barefoot doctor model and driven by the primary health care philosophy. Therefore, in conclusion of this slide, China gave us the practical model. Alma-Ata gave us the global framework, and together they sparked a worldwide movement that still shapes how we train and support the primary health care workers today. Let's look at the next slide. In this slide, you will see between 1951 to 1976, different diseases, different occurrence, all health related. You could see the 1981 first aid cases reported by the CDC. You could see in 1988 the launch of polio eradication initiative that was led by the CDC and international partners. We see in 2009 the CDC identified novel H1N1 influenza virus, and then we see in 2016 emergency operations that were centered. The emergency operation centers were activated about Zika, spreads in the Americas. We see in 1946 communicable diseases became established. The communicable disease center became established. In 1966, we see that the smallpox eradication program was launched. We could see in 1980, smallpox eradicated. First international field epidemiology training program begins. In 1982, CDC launches international campaign to eliminate guinea worm disease. And in 2003, we had the severe acute respiratory syndrome, SARS, discovered in Asia. And in 2014, CDC, response to West Africa, Ebola outbreak, the largest in history. And this is just a summary of health challenges, epidemics that have taken place over the years. In this next slide, we want to see global expansion and renewed focus on the PHC workers, which took place between 1980 to 1990. Here, countries such as Brazil implemented national community health workers programs. Example, family health program. This initiative contributed to improved maternal and child health, like I said before, and it expanded, most importantly, immunization, and then reduced hospital admission through preventive care. In the 2000s, the global health community renewed its emphasis on community health workers to bridge the health workforce gap in low and middle income countries. And so we had organizations like the WHO, the UNICEF, and Global Health Workforce. That alliance promoted the community health workers as critical to achieving the Millennium Development Goals. And so focus shifted toward formal recognition, the structured training and integration of the CHWs, that is the community health workers, into national health systems. Here you can see a historical context as well in the 1780s, 1870, and then in 1970. And then in 2010, we saw the emerge of artificial intelligence, telemedicine, and automatic health monitors. And then in 2020, we could see personalization of digital wellness. Let's see slide 20. Under this slide, we want to see the present, we want to see the expansion and the formalization of the PHC workers between 2010 till date. We'll begin with global expansion. Many countries have scaled up and formalized community health worker programs to address persistent health inequities, or you say inequalities. Number two, we saw integration into health systems, where community health workers are now recognized as essential members of the primary healthcare workforce, often linked to national universal health coverage strategies. Evidence of impact. Numerous studies confirm community health workers' effectiveness in improving maternal and child health, HIV care, and also malaria control and non-communicable disease prevention. We also see that between 2010 and now, we began to see digital transformation. That is the use of mobile health tools like your mHealth and data reporting systems has enhanced supervision. It has also enhanced accountability and service delivery. And then we've seen also between 2010 and now, policy recognition. And this is highly supported by frameworks such as the WHO 2018 guideline, which advocate for fair remuneration, structured training, and supportive supervision. Here we can see the distribution of the PHCs across the 6 geopolitical zones in Nigeria. And here you will see that the North Central has 48 primary health care centers, Northwest about 24, Northeast 34, and then FCT 83, in the Southwest 66, in the South 30, in the Southeast 18, and it is more are being added and more expansion still taking place. But you will notice that in the Northwest, that's the highest population density. You have large rural coverage. In the Northeast, you had many PHCs affected by insecurity and displacement. In the North Central, you could see moderate coverage. However, expansion is still ongoing. In the Southwest, we see a relatively better staffing and infrastructure when you visit the primary health centers. And in the Southeast, you could see moderate coverage, even uneven rural distribution taking place in the Southeast. And in the South, access limited by terrain and riverine communities. And that has been the major problem. So from here, we've seen the geopolitical zone and some very clear remarks about each of them. At this juncture, we want to look at slide 22. Still looking at historical context. Here we want to see community health influencers, promoters, and services. That's the CHIPS program. Overview developed by, as an overview that is just to look at this aspect so that we get an understanding as we begin to look at the objectives so you don't get lost. This CHIPS, like I told you in the very beginning, was developed by the National Primary Healthcare Development Agency. And this CHIPS program, builds on early community health worker models, if I may use that word. Models over the years. It was built on those models, and they included such as the CHU and JCHUs. It was designed to strengthen community-level healthcare delivery and ensure effective linkage between communities and formal health facilities. Now, what are the objectives? To enhance access to essential primary health care services in rural and underserved areas. Number 2, to bridge the gap between communities and the formal health system. And number 3, to improve maternal, newborn, and child health outcomes. Number 4, to support disease surveillance, health promotion, and behavioral change communication. This CHIPS program, what was the significance? Why was it necessary? The CHIPS initiative represents Nigeria's modern evolution of the primary health care workers concepts, which aligns with global best practices like India's ASHA, Ethiopia's HEP, and to achieve universal health coverage, UHC, and community-driven primary health care. Looking at the slide 23, where the CHIPS program will be discussed more in detail in terms of objective and structure. So, as part of the objectives of the CHIPS program, we see enhanced access. It was meant to enhance access to the health system. And we also see as part of the objective is to promote health education. That is, strengthen health promotion and disease prevention at the grassroots level. Number 3 was to facilitate referrals, to improve linkages between households and health facilities for timely care and follow-up. And what is the structure like? When you say CHIPS agents, they are organized. Each political ward engages a minimum of 10 trained CHIPS agents, preferably females, selected from the local community. These CHIPS agents, they operate at the household level, providing counseling, mobilization, and health education. They also create demand for services. They refer patients to the primary health care facilities and deliver basic preventive and promotive care. They also manage uncomplicated childhood illnesses, such like malaria, diarrhea, pneumonia. And this is essentially in children under 5 years old. At this juncture, we want to conclude by looking at the community engagement focal persons. Preferably, they are males, and they complement the CHIPS agents by promoting male involvement and community participation in health programs. And it also serves as liaisons between communities, PHC facilities, and local leaders. At this juncture, I want to thank you for listening. We have just concluded the part 2 of this lecture series. And we have discussed the historical context, and we have seen global applications and how it all began. We've seen the impact, and we have also seen the significance of all these aspects, especially the CHIEFS program. Now you know the structure, you know the objectives, why they exist. We've also seen the community engagement focal persons who are preferably males so that they can work together. And that is really yielding a lot of success. If you love this video, please click the like button. And if you've not subscribed, make sure you subscribe. Thank you. If you have any questions, please drop it in the comments section. I will give reply to each one of your questions. I'm glad when you make progress. Take time to take notes and take time to rewind and take time to listen. And I'm sure that you would have gained a lot from what we've discussed. I'll see you in the next video, the part 3 of this video lecture series, the training and support of primary health care workers. Thank you.